In the 1950s, drug testing was not as rigorous as it is today. Thalidomide was primarily tested in mice, and there was no practical dose that was found to kill an individual, so it had no reported lethal dose and was deemed to be non-toxic. However, this didn't include any testing of potential impacts on pregnant individuals or a developing embryo, which is particularly important when considering how thalidomide was marketed as a treatment for morning sickness to that very demographic. At the time, it was not universally accepted that drugs could cross from mother to child through the placenta. This contributed to the lack of testing and concern about potential side effects of thalidomide on development. This figure is a much more recent graphic of how drugs can be passed from mother to child. The villi containing some of the child's blood vessels extend into the placenta and very close to the mother's own blood vessels. Drugs in the mother's bloodstream can then cross this thin placental membrane and into the bloodstream of the child. The problem with taking thalidomide during pregnancy comes from the presence of two enantiomers of thalidomide. One enantiomer, the R form, gives the beneficial effects and is a sedative. However, the S form is teratogenic, meaning it has the potential to cause birth defects. It does so by inhibiting angiogenesis, or the formation of new blood vessels. Thalidomide was sold as a mixture of both enantiomers, so patients were receiving both the sedative and the teratogen. However, even if the drug was sold as purely the sedative form, at physiological conditions the compounds rarely convert between the R and S enantiomers. So even if only R thalidomide was administered, both forms would be present within the body. The exact mechanism through which thalidomide damages embryos is unknown, but its ability to inhibit angiogenesis is thought to be the main cause of thalidomide embryopathy. While an adult taking thalidomide would likely suffer few consequences of this anti-angiogenic effect, a developing embryo requires large-scale production of blood vessels to rapidly develop a full set of organs and limbs. The timing of embryonic development means that there are links between the time of thalidomide exposure and the type of damage experienced by the embryo. Extremely early exposure is likely fatal, while exposure very late in development is less likely to be severe. This graphic shows some effects of thalidomide in relation to the time of exposure and development. You can see that the window of time for upper limb damage is greater than that of lower limbs, and this is seen by upper limb abnormalities being more common in thalidomide embryopathy than lower limb ones. Here is a comparison of the normal development of a human arm as opposed to that of an individual experiencing thalidomide embryopathy. While a normal limb development has gradients of protein directing blood vessel and limb formation, thalidomide prevents the formation of blood vessels required to develop the limb. This lack of blood vessels then causes cell death and the complete or partial loss of the limb. Once again, we can see the difference time of exposure can make, as early or long-term exposure can cause amelia, the complete loss of the limb, while short exposure is more likely to cause phocomelia, the partial loss of limb tissue.